Welcome to our video on glycogen storage diseases. Let's get started. Here's an overview of the diseases we'll be discussing in this lecture. You can see that we'll be reviewing von Gierke disease, Pompe disease, Cory disease, and McArdle disease. Let's start with von Gierke disease. Von Gierke disease is considered a type 1 glycogen storage disease. It's an autosomal recessive condition caused by a glucose 6-phosphatase deficiency. Since this enzyme is common for gluconeogenesis and glycogenolysis, both of these pathways are disrupted. This in turn leads to glycogen accumulation in the liver and kidneys. Patients present with severe fasting hypoglycemia because both gluconeogenesis and glycogenolysis are disrupted. They also have hepatomegaly and renomegaly, which is due to excessive glycogen accumulation in the liver and kidneys respectively. Lactate levels are high due to disruption of the Cory cycle. In other words, interrupted gluconeogenesis causes a buildup of lactic acid as a substrate. Uric acid levels are also increased because lactic acid competes with uric acid for secretion in the kidneys. Serum triglycerides are increased because fasting hypoglycemia stimulates lipolysis and mobilization of the fat from the adipose tissue to the liver. Finally, patients have characteristic physical features. They have a short stature, thin extremities, and doll-like faces with fat cheeks. The management includes frequent oral glucose or cornstarch administration to counteract fasting hypoglycemia, as well as avoidance of fructose and galactose. All right, let's try a question. A 3-month-old boy is brought to the physician by his parents due to irritability and sleepiness. The patient was born at 38 weeks of gestation via vaginal delivery. He experienced 2 episodes of tonic-clonic seizures this week, several hours after being breastfed. The physical exam reveals a liver span of 18 centimeters in the mid-clavicular line and bilateral bulging flank masses. Laboratory findings are significant for hyperuricemia, hypertriglyceridemia, and increased lactic acid. His fasting blood glucose is 30 milligrams per deciliter. What is the most likely biochemical explanation for severe fasting hypoglycemia in this patient? All right, this patient is presenting with irritability and sleepiness. He's had 2 episodes of tonic-clonic seizures several hours after being breastfed. These seizures were most likely due to fasting hypoglycemia. He also has hepatosplenomegaly, which is evident by his 18-centimeter liver span in the mid-clavicular line. Additionally, he has renomegaly, as evidenced by bilateral bulging flank masses. Finally, his laboratory findings are significant for hyperuricemia, hypertriglyceridemia, increased lactic acid levels, and fasting hypoglycemia of 30 milligrams per deciliter. All of these findings are consistent with the diagnosis of von Gierke disease. Recall that this is an autosomal recessive type 1 glycogen storage disease caused by a glucose 6-phosphate deficiency. This enzyme is needed for glycogenolysis and gluconeogenesis. Therefore, the biochemical explanation for severe hypoglycemia in this patient with von Gierke disease is that both glycogenolysis and gluconeogenesis are interrupted. All right, now let's move on to Pompe disease. This is a type 2 glycogen storage disease. It's an autosomal recessive condition caused by a deficiency of acid maltase, which is also known as acid alpha-1,4-glucosidase. Consequently, there is glycogen accumulation in the heart, liver, and muscle. The pathognomonic finding of Pompe disease is hypertrophic cardiomyopathy due to glycogen accumulation in the myocardium. In fact, hypertrophic cardiomyopathy is the most common cause of death in these patients. Pompe disease is also characterized by hypotonia and macroglossia. Finally, patients have a poor prognosis with an early death. The management includes enzyme replacement therapy with recombinant human acid alpha-glucosidase. Okay, now let's discuss Cory disease. Cory disease, which is a type 3 glycogen storage disease, is an autosomal recessive condition caused by a debranching enzyme deficiency. Recall that debranching enzymes remove the branching polysaccharide chains from glycogen. Since this enzyme is used only in glycogenolysis but not gluconeogenesis, glycogenolysis is impaired, but gluconeogenesis is intact. This in turn leads to glycogen with an abnormal structure which accumulates in the cells. Cory disease is similar to von Gierke disease but milder in severity. It's also characterized by fasting hypoglycemia. The lactate levels are normal, which is in contrast to von Gierke disease. And finally, patients may have cardiomyopathy. The management includes a high-protein diet with cornstarch supplementation. Okay, now let's discuss the final topic, McArdle disease. McArdle disease, a type 5 glycogen storage disease, is an autosomal recessive condition caused by a myophosphorylase deficiency. This enzyme is also known as muscle glycogen phosphorylase. This enzyme is essential for glycogenolysis in muscle tissue. Therefore, in McArdle disease, muscles cannot break down glycogen into glucose. However, the liver can still perform glycogenolysis and gluconeogenesis, which is why the blood glucose levels are usually unaffected. Patients with McArdle disease usually have muscle cramps during exercise, which is due to insufficient ATP production in the muscles. Additionally, they may experience myoglobinuria in case of rhabdomyolysis. This liberates the potassium from muscle cells, resulting in hyperkalemia, which can then cause arrhythmias. A pathognomonic finding of McArdle disease is a flat venous lactate curve with a normal rise in ammonia levels during exercise. Let's take a step back and explain why this happens. During exercise, lactate production in the muscle normally increases due to glycolysis, and the ammonia production increases due to breakdown of AMP and branched chain amino acids. In patients with McArdle disease, glycogen cannot be broken down into individual glucose moieties. Therefore, glycolysis is impaired and the lactate production does not increase. However, these patients can normally break down AMP and branched chain amino acids, which results in high venous ammonia levels. Finally, McArdle disease is characterized by a second wind phenomenon, which represents an initial muscular weakness followed by normalized muscle strength, which is due to increased muscle blood flow. The management of McArdle disease includes avoidance of strenuous exercise, sucrose ingestion before exercise, creatine supplementation, and ACE inhibitors. All right, let's finish up with a final question. A 16-year-old girl is brought to the emergency department due to severe muscle cramps and dark urine. She was exercising in the gym when she suddenly felt diffuse muscular pain and an irregular heartbeat. Urinalysis is significant for 3+ red blood cells, but urine microscopy reveals no erythrocytes. Laboratory findings are significant for a creatine kinase level of 2000 and a potassium level of 5.4. Similar episodes have happened to her older brother and sister. She intermittently experiences muscle pain after exercise. However, her cramps usually resolve after eating food and having a short period of rest. What is the best explanation for this patient's increased exercise capacity after rest? All right, this young patient presents with severe muscle cramps, dark urine, an irregular heartbeat, a creatine kinase of 2000, and a potassium of 5.4. These findings are consistent with rhabdomyolysis. Given her age and the fact that her brother and sister are also affected, she most likely has a genetic disease. And this is classic for McArdle disease, which again is caused by a deficiency of myophosphorylase. The question stem states that she intermittently experiences muscle pain after exercise. However, her cramps usually resolve after eating food and having a short period of rest. This is describing the second wind phenomenon, which is characteristic of McArdle disease. This is explained by increased muscular blood flow after a short period of rest. So the answer to the question is increased muscular blood flow after a short period of rest. And that concludes this section.